I think all of our Region 4 folks have really done it. I shouldn't say only our Region 4, Region 1, 2, 3, and 4. All the panelists have done a superb job. So now's time for the committee to get to ask you Region 4 folks questions. And so far, I don't see any will they be in the chat or in the participants, Elizabeth?
People will be raising their hands, so you'll see them in the participant list.
So Kevin Elliott has his hand up.
Okay, Kevin, thank you.
Yeah, once again, thank you to everybody who spoke. Really appreciate their input. I wanted to actually go back to Lamisha, although others are welcome to share their thoughts on this as well. I really appreciated your comments about the concerns of Black and Brown communities. And I just wanted to give you an opportunity to elaborate at all. If you had particular thoughts for physicians as they're working with these communities, the guidance that you would have for them in, just things to consider. I noticed your last slide, you had a little something about language justice that I didn't know if you could elaborate on that or any other issues that you thought were relevant for us to consider giving guidance to clinicians.
Sure thing, Kevin. Thanks for the question. So I'll include it kind of in different buckets because the rural versus urban divide, right? So there's different needs. So some feedback, there are universities such as East Carolina that works directly with clinics and urgent care, such as Vidant, which is a primary provider in the East, due to the fact that our, again, rural hospital access is a desert. And so being able to work with universities to provide plain language clinical guidelines, translated materials that are accessible for communities with disabilities. So what is available for folks that are auditory learners, visual learners, but the like when we're talking about the whole spectrum. The other element is what are opportunities to be able to work with the communities is also very critical. The community culture in certain areas of North Carolina, specifically the East, is not just language justice that includes Spanish, but it's also language justice within Black communities. So how are clinicians working with churches, Divine Nine, local civic and social organizations to be able to help you outreach in a way that makes sure you're in direct contact with community members? The other element is that we've also had issues with some of our clinicians have two things. Haven't included PFAS as an underlying cause on permanent medical records because of two issues. One, the misinformation or uneducation around what PFAS actually is and the burden of the community to explain it when the community is still just trying to grapple with it themselves. And then two, is the fear of pushback from the corporation itself. And so this results in insurance concerns with not being able to actually provide the blood testing support financially for these communities if these communities have insurance. So that's another thing, right? Being able to have these clinical guidelines and it being in plain language for our communities so that our doctors are supported and our physicians are supported to feel confident that they won't be sued and that it isn't on the burden of our communities to try to translate in community speak why they feel bad. Why do I feel awful? And then how do we make sure that clinicians are supported with the information of broad contaminant? So when we're talking about COVID-19 exacerbation, I've already mentioned cumulative impact. There are many things that exacerbate health disparities for our communities. And so if clinicians are not prepared to engage around PFAS, plus you live beside a CAFO, plus you live beside coal ash, then we're not going to get to the underlying cause and instead treat the symptoms. And so that main thing is partnering with the groups, plain language, and then making sure that you're actually providing support on insurance so it's not coming out of pocket for folks, and then making this accessible in urgent cares, free clinics, shelters, and folks where not traditional populations go for services.
Well, thank you, Kevin, for a great question, and Lamisha, thank you for a great answer. We have a question from Tamara James Todd.
Hi, everyone. Thank you so much for what has been really insightful and helpful presentations. My question is for any of the panelists. You all have mentioned, the need, and this echoes kind of throughout the day, training of physicians and, being able to also have had them ask additional questions as a part of, various pieces of the intake process when seeking out medical care. I'm curious to what extent you've seen that increase. I think the last speaker mentioned that is something that has started to occur to some degree. And I'm curious also what if at all you all have had interaction through your organizations or as individuals with your region's pediatric environmental health specialties units. I believe one of the presenters mentioned something to the effect of we need something like what we have for lead and lead exposure as it relates to, being able to have a way forward as far as protocols go. And so I'm just curious if you as individuals or if, other members of your community or even the medical, and healthcare providers that you have interacted with have had any interaction as a part of that kind of training of physicians with the pediatric environmental health specialties units.
I think that I had brought up the protocols for using the same protocols for lead exposure, and what I had the opportunity to do just last night was sit for 3.5 hours with a physician who's been treating for almost 20 years, thousands of patients in the area locally that actually had some awareness about PFAS contamination. So it was so refreshing. In between his signing his loan documents, I kept asking questions and kept addressing. And so we got on this dialogue, and that is really what has to happen. That conversation has to happen. Maybe he felt fairly safe. We were sitting in a closed office. I think that is what I see in my community is that it's don't talk, don't tell kind of attitude. And so physicians aren't going to feel comfortable unless they feel safe to address the problem. But I think having a directive, having something that says this is how this needs to be done, will give them the free rein to address it, especially when it concerns the children. As adults and having been exposed for possibly decades already, I don't know. We're really not at a place where we can say this is going to leave. Our generation has been impacted. I'm concerned about the grandchildren, the children, the babies that are yet to be born. That I think needs to be the first. And if anybody says that that's not something that we should be concerned with, then I don't even know what to say, because you can't argue that children, those that have a life ahead of them, we hope, should not be the first consideration of every single living adult. So I'm hoping that I can, if nothing else, guilt people into doing the right thing.
Cheryl, thank you. Do any of the other panel members want to respond to Tamara?
Well, one of the things I find, I didn't hit this up in the thing. I got diagnosed with polycythemia. I don't have polycythemia vera, which is leukemia. I have pre-leukemia, but there's 15 to 20 different illnesses that have started occurring 18 months to 2 years after I moved to this area. I make a joke on PBS NewsHour. I made a joke. 23 years in special forces, an enemy couldn't kill me, but my water is going to. And one of the things that I have communication with the outreach group we reached out to is I started finding pockets of different illnesses that follow the wind band of where the air emissions went. So the interesting thing is my oncologist, hematologist, I was talking to him about polycythemia, and I'm going, as they're taking blood out of me, and I'm going, the odd thing is, I go, I met 11 of your patients, and I start naming them off, and I go, all of them have the same stuff. We all have vitamin D deficiency, testosterone issue, and I start naming them through, and he goes, what do you mean? And I go, we all live in a PFAS contaminated area, and he goes, that's interesting. So, guidance to the medical community, I don't see it making it from Cumberland County to the doctors within Cumberland County. I don't know if Lamesha saw that or not. Bladen County, definitely not. And then, Robinson County, I'm not seeing it, but they need something to look at to kind of help guide them.
That's right, Michael. It's that same thing, Mike. Absolutely same thing. And one thing I just want to quickly elevate is also the products that are given to expectant mothers. We found that feminine products such as Thinx underwear actually has parts per million ppm of PFAS in the actual lining. And so what are the products that are both for the mother and also for the child prenatal and post that is increasing that exposure, and how can our clinicians be supported in knowing, right, accessing that information and then accounting for it over long-term data health tracking to make sure we're clear on the products that need to be given to our communities and what products don't.
I think I would also like to add the concern of breastfeeding. I think that it's a really controversial topic, but it's one that really needs to be focused on. And there needs to be a certain understanding of when you're in a highly contaminated community and you know that you're exponentially giving that newborn, an infant, more PFAS than their body can handle. Is that worse for their body? And as a mother, if I had that choice, and what I'm hearing from all of the other communities is that we would bottle feed. We do not want that emotional burden of passing on extra PFAS to our brand new baby.
I'm going to have to comment. I'm not sure if I'm supposed to, but I just want to comment about the breastfeeding and the breast is best issue. This is an issue that has been of concern with persistent contaminants for a long time. And there were actually studies done related to comparing. These were with PCBs and dioxins, so not with PFAS, but it was clear that babies who were breastfed, even to very high levels, still did. And you compared women so that their at birth, the levels in their blood was the same. And it actually turned out that the babies who were nursed did better than the babies who weren't, even though they were getting a big dose of these chemicals from nursing. And part of the reason for this, and this is not an encouraging reason, is that in utero exposure is the most sensitive window. So by the time the baby's born, it's already past the placenta. And so I think this needs to be looked at very carefully related to PFAS, but I don't think at this point we know that breastfeeding, even if you have high serum levels, is worse for your child than not. So that's just okay. I think we better go on. We've got one more comment from Jane Hoppen, who's one of our stars in this area. Jane.
Oh yeah, and thanks Mike and Emily for acknowledging our Gen X study, and we couldn't do it without you guys. One of the things I think that particularly the Gen X story brings up is that our panel is not going to be able to make recommendations for Gen X, naphthalene byproduct 2, all those unique chemicals. And so how do you guys feel that we're still not, we may be able to make global recommendations for PFAS as a category, but how do you feel about the lack of ability or what we should do given that there's very little information about these new chemicals and they're unique? There's some unique to chemours, but probably these other communities, particularly living near Cape Canaveral, also have. And so what are your feelings about the recommendations as a class versus individual chemicals, recognizing that we won't be able to make recommendations for all the things that we know are out there?
So I know you know my thoughts, but I'll share them broadly to everyone else. We can't let this be a reason to allow the continuation of inactivity. And that is by design, and we know that the industry has basically tied medical guidance hands behind their back for this very reason. And this is where I guess I push back to the think tank that's happening here is what can you do with the resources you have, recognizing that is the threat and that is the reality. How can you push around it? Can you push around it? we need you to push around it. I mean, I think that's ultimately where our community is at, is this is an injustice that needs to be addressed with whatever you can throw at it. And it does need to be addressed from a class approach, we feel. And I'm hearing that there's a lot of data out there to support making some inferences and some reasonable assumptions without having the security of that neat, tidy bow of how the scientific process fully works.
I kind of mirror what Emily said. You know, one of the things that's happening in North Carolina right now is the groundwater standard as it regards to PFOA, PFOS is being looked at to basically adopt the EPA 70 parts per trillion combined or individually. From a groundwater user perspective, that's great when it comes to PFOA because the IMAC is so high right now. But for PFOS, the practical quantitative limit, which is the North Carolina law, is 2 parts per trillion. We're going to go up to 70. So going the class way, like Emily was talking, looking PFAS as a class, any movement forward to get any guidance or input to help in that movement to adopt it as, you know, if they looked at PFAS as a class, 10 parts per trillion, 70 parts per trillion combined, okay, you know, that's kind of like what happened in the consent order, but it's only for 12 chemicals. If they look at that over a broad base, I mean, Wilmington has a lot more chemicals that were in the river that they saw than what they see in our wells. So, you know, I think any movement forward is better than no movement. You know, it's kind of like if Clean Cape Fear River Watch didn't sue DEQ, we wouldn't have a consent order at all. So forward movement is better than none.
Well, I want to thank this panel. It's just been fabulous. You know, without your activities, we would have moved nowhere. And we need you to continue, even when at times it probably gets exhausting to do this, and really try to start. Well, I would urge you to start pushing PFAS as a class issue, because we're never going to be able to get all that nice data on 10,000 different ones, never alone monitor them. So with that, I'd like to turn it back to Ned, because we have a whole bunch of wonderful people who would like to make comments from the audience.